And again, we have Dr. Lynne Smith from Harbor-UCLA Medical Center, and I'm going to let her take it away.
Good morning. I have to admit I'm a little nervous because I've never given a teaching like this, but I am thrilled to be here and to talk to you about our work as a team on methamphetamine. And hopefully by the end of the talk, you'll have a little greater comfort level about methamphetamine, who uses it, why they use it, and what can we anticipate in terms of children who are exposed during pregnancy. So I have no financial disclosures other than to let you know that the majority of this work was funded through the National Institutes of Health, through NIDA, and I will be discussing much of the information that I'm conveying to you about child outcome was funded by the National Institutes of Health. So we'll briefly go over a little bit of general information about methamphetamine. Also touch briefly about the environments in which children are raised and how that can affect them if they're in an environment of active users. But the majority of this talk will be about prenatal methamphetamine exposure and what to expect in children for both development, behavior, and for their own growth of their body. So sometimes people ask me, why should this be studied? If you find that methamphetamine is good, we're not going to recommend it. So why would we even study it to begin with? And it really falls into many reasons, but one of the very important reasons is issues related not only to adoption, but kinship care as well. When I started in the early 90s, cocaine was very prevalent. And oftentimes, kinship care providers, potential foster parents, potential adoptive parents, were really worried about taking on these children because of what a lot of news in the headlines was talking about, and we'll get into that, about how bad it was going to be, how awful these children were. And it was very important, I think, to study this to show that these children actually thrive in supportive environments. And also, I'm going to touch briefly on the lessons from cocaine. So these are actual headlines from the New York Times, LA Times, other major publications. Back in the 1980s, cocaine is a vicious assault on a child, a joyless view, disaster of historic dimension, epidemic, bleak for crack babies. And though it's fair to say that sometimes we are concerned about people maybe over-dramatizing something, in fairness to reporters, this was not an over-dramatization. This was in response to a New England Journal of Medicine article. And in that article, they found that children who were exposed to cocaine had very bad outcomes relative to children who were not. However, it was not conducted in Los Angeles. But when you really looked at the children that were studied, they looked at children in impoverished areas with multiple ACEs, multiple factors that could lead to an adverse outcome. And they compared them to children who weren't exposed to cocaine, who lived in the equivalent of Brentwood or some other very rich area that didn't have these adverse childhood events. And once a good study looked at children who were exposed to ACEs as well as cocaine versus children who were also in a similar environment but not cocaine, the headlines changed. The crack kids are not broken. Researchers debunked the myth of the crack baby. And at the time that methamphetamine was first starting, people were starting to also discuss that methamphetamine is also going to be a lost generation. And hopefully by the end of the talk, you'll understand that that's not true. Worldwide, several million methamphetamine users, which is similar to heroin and cocaine abuse combined. And methamphetamine remains one of the primary drugs of dependence in the United States. In the Western and Midwestern states, though a recent surge in the South and East as well. And if you follow along, these are the darker colored states are the states in 2000 that had a heavy methamphetamine use. And if you go across, you can see that methamphetamine became a serious issue across all the way, if you will. This is the Mississippi River. And you can see to the Mississippi River, it absolutely was heavy, heavy use. And then in the early 2010s, it actually started to get to the East Coast and to the Southeast. This being my favorite bad crook story, Texas man in jail after attempting to deposit meth at bank. But basically it's showing that methamphetamine, as it was slowly decreasing in the West in the early 2010s just a bit, it was starting to heat up in the East and the Southeast and Southwest. Women comprise nearly half of those seeking treatment of methamphetamine abuse. When you looked at SAMHSA data, looking at individuals who were seeking drug treatment in drug treatment centers. And in 2011, nearly 6% of individuals seeking drug treatment for methamphetamine abuse in the United States were pregnant. So why do people use methamphetamine? Basically, when you first start using methamphetamine, it is a fantastic drug that, if you will, markets itself. It allows you to have increased attention and decreased fatigue. Very popular with World War II pilots, truck drivers, night shift workers. It leads to a euphoria that lasts for days. It gives you higher self-esteem and confidence and increases libido. It's an appetite suppressant. It's affordable. It's long-lasting. But, and I often give this talk to very hardworking nurses and doctors and medical students, this is what I like to liken a 2-week honeymoon in a 50-year-long slog of a horrible, awful marriage. My husband saw me give this talk many years ago, and he asked me to emphasize that I am not currently in one of those marriages, but he did want to be sure I conveyed that. But it is a great analogy, because very shortly after this wonderful, if you will, high and euphoria and energy and ability to multitask, intense craving begins, tweaking, repetitive motor activity, paranoia, hallucinations, rage, and violence. This is part of what they call the mugshot project. And this is a woman who is 38 years old. And this is her 3 years later at the age of 41. I think you can see where she's picked, where she's just ravaged by this drug. I gave this talk, or showed this picture to my son when he was 14, and unfortunately, he thought that this could be consistent with the natural aging process of a 38-year-old, which broke my heart and caused me to try to find a picture that he could better relate to. And this is the mugshot of Miss Teen Oregon World, and this is her 5 years later after having been ravaged by methamphetamine. This drug is an absolute horror for people, and the problem is it's so gratifying for those first few weeks. And kids, young adults are, we know about edibles for marijuana, but, drug distributors are very market savvy. So this is Strawberry Quick, which they used to sell in the stores, and this is Strawberry Quick. This is methamphetamine. This is ecstasy. These are the Halloween candies that used to be made with great regularity, and this is ecstasy. So they're definitely marketing toward children or young adults. I'm not going to spend too much time, but I think it's helpful for you if you're working with someone who is struggling with methamphetamine to understand just a teeny tiny bit about the biology. And some of this is likely a refresher course for many of you. But basically, in order to get messages across in the brain, one neuron, one brain cell, if you will, talks to another brain cell via chemicals. And the chemicals that is impacted by methamphetamine and cocaine is dopamine. And what happens is there's no message being sent if no message needs to be sent. But if you want to say a message, if you want something to activate within the brain, then these vesicles that hold dopamine in the presynaptic neuron, they send a message into this space between, and this is dopamine, and here it comes from the first neuron to the second neuron, and it attaches to these receptors on this postsynaptic cell, and the message is sent. Let's say the message is good morning. So that message is sent, good morning, and then this then detaches because the message has been sent. It is then reuptake into this cell and ready for the next message when it comes. So the message is good morning, the message is sent, then these chemicals are then reuptake, and the message has been concluded, and then this conversation, if you will, is over. That is the normal conveyance of information. With cocaine, what happens is it blocks the reuptake of this chemical. So it allows for a more intense message to be sent between the first cell and the second cell. So instead of good morning, it's more like, good morning. And that is the high that people experience with cocaine, but it's a relatively short-lived high. And eventually, these chemicals go back up into, they get reuptake just more slowly, if you will, back up into the cell. So it's the same amount of chemical in here, but it stays a little longer. So it's not good morning, it's good morning. Methamphetamine works the same in that as cocaine, in that it does block the reuptake. And methamphetamine is depicted in this as a triangle. So here's the first cell with the messenger chemicals, here's the chemicals, and here's the second cell. And methamphetamine does indeed block the message, but it also gets into these vesicles and causes a massive expulsion of dopamine into this synaptic cleft. And so it's, instead of saying good morning, like cocaine, it's as if someone has a tape player and it screams, good morning, for hours and hours. And that's what happens in the beginning when someone uses methamphetamine. They have this long-lasting high because not only does it block the reuptake and allow this message to stay for a long time, there's far more message being put into this area. Now, the first couple of times someone wishes you a very loud, long, hours and hours long good morning, you might be able to stand it. But if you were sitting in that room every day for hours and hours and hours on end, what would you do to your ears? This is basically ears, if you will, of this second cell. Well, you'd probably block your ears because you wouldn't want to continue to hear this message for such a long, loud, intense period of time. And indeed, that is what happens with methamphetamine. The number of these postsynaptic ears, if you will, or receptors, decreases. So the person then constantly tries to find that first 2-week honeymoon and uses more and more and more often methamphetamine to try to get that wonderful experience. But instead, these postsynaptic neurons basically shut their ears down and they stop receiving this message. And that's what then causes the methamphetamine user to descend into this horrible, awful period that you saw physically, you could see in those mugshots. And this is actually a brain study of these, if you will, ears of the postsynaptic receptors. And this is normal. This red hot is a normal number. And you can see it's cooled off. It's far fewer in someone who's a recently abstinent methamphetamine user. There's good news. If someone stays off methamphetamine and you then measure them again months and months later, they return to a state of more receptors and more ears. So there is hope for methamphetamine users if they can stay abstinent for a period of months. In terms of the home environment that a child might be raised in, these are the effects of methamphetamine on a chronic user: impulsivity, distraction, poor attention. Executive function is basically the ability for you to sit and listen to this talk and stay engaged when perhaps you'd rather be somewhere else, maybe the beach. So that's executive function. And parents have a very difficult time. They're depressed, they have violent behavior. I think all of us, if we were to list a wonderful personality characteristics of a parent, really none of these would be on there. So they have a very difficult time, especially in the recently abstinent period, of being able to attend to the needs of another. I'm a very visual learner, and just this is the home of actively using methamphetamine parents, and you can just see this as a physical representation of the home environment that children can be exposed to with active methamphetamine use. And oftentimes it's manifest in impaired judgment, so poor supervision, doing binges and crashes, forgotten meals, sedation with Benadryl or benzodiazepines. Remember, this is a long-lasting high, and so they're going to crash for many, many hours. And they want their child not to, either they want their child to be safe, or they just don't want to be interrupted by their sleep. And so they'll sometimes drug their own children with Benadryl or benzodiazepines to have them sleep. This is just a picture of a child's baby bottle, and this was refashioned into a methamphetamine smoking pipe, just to give you a sense of maybe the disordered thought of someone who's actively using sometimes. And this is to the extreme that methamphetamine addiction can lead some individuals to even extreme behavior. In the setting of clandestine laboratories, which is where methamphetamine is produced, you can produce it in a home laboratory. This is Sudafed, and this is methamphetamine down here. And really the only difference is this one little hydroxyl group. You can go online and find out how to make Sudafed into methamphetamine. And that's why Sudafed became a tightly controlled drug in California and in across the country. Although you can get Sudafed imported from Canada, it's very easy to get it, and that's what major drug creators, drug laboratories can do. But it's been made more difficult here locally in the state of California and across the United States. In California, the number of clandestine laboratories used to be nearing the 1,000. You can see that it has really been cut down primarily because Mexico is such a proficient creator of methamphetamine. But you can see east of the Mississippi River, it is because states in the West have been exposed to all of these issues since the early 2000s and even into the late 1990s. The East Coast is slowly catching up, and there are many, many clandestine laboratories. But if there are kids exposed, these chemicals are extremely dangerous. And in fact, 1 in 6 laboratories, clandestine laboratories in California, are discovered because of explosions. And you would think that these states that adopted, Oklahoma adopted the law first. California was an early adopter before it became a nationwide law to regulate Benadryl, Sudafed. But what really caused states to regulate Sudafed was not methamphetamine and trying to protect their citizens from this drug. It was because the burn centers were being overwhelmed, and the cost of third-degree burns in all of these states was so overwhelming and impactful on states that they basically had to tighten down and decrease these clandestine laboratories because of the issue of explosions. And this is what happens when you find a clandestine lab. Many of you may have experienced what we call meth mouth. You know, I used to think when I was first working with folks that it's because, well, you know, they're using meth and they're not brushing and flossing. But, you know, many of our clients who are struggling with addiction don't brush and floss. It really is because of the corrosive materials that are used during the methamphetamine creation process. And this is just a home that was a clandestine laboratory. This was Pepsi. This, however, was not water. This was lye, and it was ingested. So you can imagine that if there is a clandestine laboratory that these kids are exposed to, they're exposed to dangers from innumerable sources. So that's your brief-ish overview of the drug and its impact on the user and how it can impact the environment in which a child is being raised. I'm now going to address the primary focus of this talk, which is what are the effects we might be able to anticipate, if any, on children who have been exposed to methamphetamine use during pregnancy. So before, years and years ago, before the IDEAL study that we are going to talk about, the most information we had came from a sample of children in Sweden, 65 children who were born to mothers who abused amphetamines during their pregnancy, and serial developmental and growth assessments were performed before from birth to age 15. And from infancy, it was found in the first few months of life, these babies were actually pretty drowsy, and they had some speech problems. By age 4, the amphetamine-exposed group was lower than the comparison group. However, please note the IQ was perfectly fine in both groups, 103 versus 110. So though the conclusion was that the IQ was lower, to be frank, this IQ was just fine. By age 10, 12% attended a class below the norm for their biological age, where in the control group it was less than 5%. And then psychometric testing correlated negatively with increased exposure to amphetamine. So a dose response, they did less well behaviorally and developmentally with the higher amphetamine exposure. By age 4, they had more aggressive behavior and peer-related problems, which was improving by age 8, but still more pronounced in the amphetamine group. Adjustment, they had a poor adjustment at ages 4 and 8. Those who were living with a mother who continued her drug use had more issues with aggressive behavior and adjustment disturbances. So again, also including a bit of the environment in which they're being raised. By age 15, they had delays in math and Swedish language, with 15% one grade lower than expected, and 12% were receiving special training or vocational training. And they had very pronounced difficulties with physical fitness. However, the sample size was very small, and there was no control group. The authors just couldn't find a group of peers who had been raised in an environment with many adverse childhood events and exposures without having also had drug exposure. So they basically normed them to their non-exposed peers. There were multiple drugs of exposure, including opiates, and we know that opiate exposure in and of itself is a risk. So it was tough to know, was it amphetamine or was it the co-exposure to opiates? And it relied solely on maternal self-report. So because of the issues that we talked about earlier in the talk about concluding that methamphetamine or amphetamines are going to produce all kinds of problems, we basically studied in a well-controlled environment via the NIH funding mechanism children who were exposed to methamphetamine, but also who were relatively well controlled. And we'll talk about the control group. And basically, this was a grant that was primarily through Brown University because they had done such a beautiful study on children exposed to cocaine. But remember, they didn't have methamphetamine in the East Coast when this was started. So the recruitment centers were the universities of Oklahoma and Hawaii. In California, Harbor-UCLA, as well as Long Beach Memorial, and then Blank Children's in Des Moines. And we screened several thousand, approached several thousand, and there were many ineligibles, often because they had, at that time, there weren't measures that if you were not English speaking, it was very difficult. There weren't normed measures, and so that was the primary ineligibility. And so about a quarter of people who were eligible consented, and of the 3,700 who were consented, all who used methamphetamine or exposed pregnancies were included. And the unexposed, we'll talk about in a moment, were taken from the remaining 3,500 enrollees, and they were matched 1-to-1. And we'll talk about how that was done. So basically, we compared the exposed subjects and we matched them. If the Oklahoma site had a methamphetamine-exposed baby, mother-baby dyad, then the next mother-baby dyad who was unexposed but had similar race, a similar birth weight, maternal education, and we used maternal education either being less than 12th grade or 12th grade and higher, and type of insurance. The recruitment for this study occurred prior to the Affordable Care Act. So type of insurance and maternal education were used as proxies for socioeconomic status. Exposure was determined by maternal self-report as well as GCMS confirmation of amphetamine in the meconium. Alcohol, tobacco, and marijuana use were included in both groups because, quite frankly, if they weren't, you couldn't do the study because alcohol, tobacco, and marijuana are such common co-exposures and co-uses with methamphetamine. LSD, PCP, and importantly, opiates were excluded. So remember those teeth that I showed you with meth mouth. If a woman who had used methamphetamine had gone to the dentist one time and received one dose of an opiate, she was excluded from the study. So the maternal characteristics we did match based on race, and we did based on high school education. So there were no differences, and you can see there was significant distribution across in terms of racial distribution. Though we did our best attempt to match for socioeconomic status, those who were exposed, the methamphetamine group, did have lower socioeconomic status as assessed by the Hollingshead. They were more likely to have a total family income of less than $10,000. The moms were slightly older. In addition, though there was prenatal care occurred later in gestation in the methamphetamine group, and thus had fewer prenatal care visits, though most had prenatal care and quite a number of visits. Maternal weight gain was significantly higher in the meth group, and you might ask if methamphetamine is a appetite suppressant, which most certainly it is, why they would have greater weight gain. And that's because many of the women in our group, once they learned they were pregnant, struggled and tried mightily to stop their methamphetamine use during pregnancy. And once they stopped, then, as many of you know, working with these women, they oftentimes gain 10, 20, 30 pounds sometimes. And so that's probably why their weight gain increased. Though the comparison group actually had a significant tobacco and alcohol and marijuana use, certainly there was more of these co-exposures in the methamphetamine group. I want to let you know that when I am presenting any data that is of developmental outcome, all of the data that I'm talking about will have been controlled for these differences, will have been controlled for SES, will have been controlled for these co-exposures in the modeling. So, and only when the p-value for development then is less than 0.05 and significant will it be reported. So I do want to assure you that all of this is taken into account with the data, and only if you account for all of that and above and beyond we see differences between the meth and the comparison group will we say that there were differences in these two groups. In terms of maternal characteristics during labor and thereafter, the only difference, and you know the things we think about like abruption and previa, the only differences that we were able to glean was that there was evidence for fetal distress based on OB assessment in the meth group, somewhat higher than the comparison group, but otherwise there weren't differences in the women that we recruited. Newborn characteristics, what I would take away from this is that there isn't like a congenital Alcohol exposure can lead to fetal alcohol effects, fetal alcohol syndrome. There aren't, if you will, a genetic phenotype or characteristic of children who are exposed to methamphetamine. That's what I would take away from this slide. Newborn characteristics, what I would really focus on for this is that this one down here, drug withdrawal requiring pharmacologic treatment. Basically, if you have a baby who is methamphetamine exposed, you're always going to do a newborn abstinence syndrome scoring assessment, as we all should. But if they get to the point where they require pharmacologic intervention, then they likely are not only methamphetamine exposed, but you likely have opiate exposure as well. These children, I want you to note, they will be jittery. They will have more likely to have a poor suck, much more likely to be admitted to the NICU. But the classic opiate exposure where they're rubbing their knees and having diarrhea and all these classic that we think of on the Finnegan scoring, it is not typically methamphetamine. There were 2 that were treated, but sometimes we weren't, as a study, we didn't dictate to a clinician whether they treated or not. And in this era, in contrast to the era that this study was recruiting in, which was the early 2000s, jitteriness would sometimes get some clinicians to treat. But realistically, yes, they'll be jittery. They can actually be jittery for months, but they do not require pharmacologic intervention. In terms of developmental, what did we find in the newborns? And you might ask yourself, how do you do a developmental assessment on a newborn? There is the NICU Network Neurobehavioral Scale, which was administered in the first 4 days of life by a certified examiner who did not know whether the baby was exposed or not. And the ENDS is a standardized assessment for assessing at-risk term and premature infants, and it measures stress abstinence, neurologic function, and behavior. And what you would do is you'd take a baby when they were right after a feed and they were nice and comfortable, and then you introduce stressors to them. You arouse them by basically uncovering them, and they get arisen from sleep, and you do certain reflexes. Many of you may have seen, physicians do some of these reflexes. And then you introduce, this wouldn't stress me out particularly, but it is a stressor for a baby. And you watch how they awake, you watch how they respond to a stress, and you watch how they self-soothe. So these are all aspects of this ENDS assessment. And what we found was this is methamphetamine, and these green, if you will, are the control group. And what we found was actually consistent with the group in Sweden, which is that these babies were actually very difficult to arouse. But once they were aroused, they were much higher stress, physiologic stress and state stress. I won't get into the science of cry, but I will just say that these children have a much more reactive, noisy, unstable cry. And if any of you have ever lived with a newborn, they're very difficult to live with because they're up every 2 hours. And think about someone who is recently abstinent, who is struggling with their own drug dependency and their own recovery, and dealing with a more stressed baby. And let's just say that these cries are much more frustrating and annoying to deal with. And there was a bit of a dose-response effect. So this is the amount of amphetamine metabolite that you see in the meconium, and the more methamphetamine that was in the metabolite, the poorer the quality of their movement, the more stressed they were, and the less able they were to regulate themselves. So once they were stressed, the less able they were to self-soothe. So one of the questions, if they have noisier cries and they're more stressed out, one of the questions that I would want to know if I were going to be a kinship caregiver, if I'm recently abstinent, is will this go on forever, Or will this get better? And I want you to know there's great news. This gets better. The newborn versus 1 month ends for the meth exposed. So these are all methamphetamine exposed babies. So the newborn meth exposed and the 1 month meth exposed. Their arousal is back to normal, and more importantly, their stress levels, which were much higher at birth, are back to the same as a comparison group, the same as any baby that is a 1 month old. So yes, in the initial few, first couple 3 weeks, you may have this unstable cry, they may be stressed out, but great news, they resume. Their stress levels are no different than any other child by 1 month of age. Between ages 1 and 5 years, we had multiple assessments of IQ and development, motor and behavior. What I will say is there have been no IQ differences in cognition between the two groups at age 2.5 years. In development, using the Bailey, at this time it's the Bailey 2. Now we know we're about ready to embark on the Bailey 4. But at this time, the standard of care, if you would, was the Bailey 2, and there were no differences on the Bailey at age 12 and 36 months. Motor. We used the Peabody Developmental Motor Scales at 1 year and 3 years. I hate busy slides, but I purposely made this busy to show you that basically the motor is fine. At 1 year, the exposed group had a worse, if you will, grasping score, but by 3 years, no differences. Remember they talked about kids in PE and the issues with their motor, but by 3 years of age, they had no differences, and I think you can appreciate this is a fairly modest finding at 1 year. So far, the only thing I would say was, what we did find was that there was, with the grasping, a dose response. So the heavier the meth use, the more likely you were to see a poor grasping score. Now, IQ was okay, development was within normal, motor slightly different. Okay, how about the behavior? The child behavior checklist was assessed at age 3 and 5. And the methamphetamine group is in these open bars. The comparison children, the unexposed children, are in the closed bars. And this is at age 3. And this is age 5. So emotional reactivity, children in the methamphetamine group were more emotionally reactive at age 3 as well as at age 5. Anxiety, depression scores, again, higher in the methamphetamine group at age 3 and at age 5. And the characteristic I think we think most about as this externalizing behavior, this act, if you will, for lack of a better term, hyperactive or high energy. We don't see differences at age 3, but we do see higher scores for externalizing behavior at age 5. And ADHD score, again, higher, not at age 3, but at age 5. And again, for attention and withdrawn behavior, you'll see heavier meth use. And I should tell you that heavier meth use was decided if you use 3 days or longer in a week. Because remember, they use and they're up for nearly a day and then they crash. And so 3 days or more was considered heavy use. And again, we saw with attention issues, a dose-responsive effect. So a little bit heavier use, we're more likely to see attention problems in these children. At age 5.5, we actually tried to define executive functioning. So in these children. So again, the ability for you to attend to this talk, the ability for you to sit through any kind of maybe a meeting that might not be to your liking. It requires 3 abilities: inhibitory control, not walking away, if you will, and going to the beach at this moment. It requires working memory and cognitive flexibility. And at age 5.5, we tested inhibitory control in these children with what's called the Hearts and Flowers dot task. And what we did was we put the child in front of a computer screen. And we had, if you'll just focus on this side for a moment, congruent task, which is if you see on the left side of the screen there's a heart, then push that screen on the left side. And if you see a heart on the right, then push the heart on the right. This is very intuitively obvious. I see a heart on the left, I push the left. If I see a heart on the right, I push the right. We also did, it's called the hearts and flowers, because we also would flash on them in a computer screen a flower. And if a flower was on the left side, instead of pushing the left, no, you need to inhibit your instinct. You actually are supposed to push the right side of the screen. And if you see a flower on the right side of the screen, inhibit that natural inclination to push the right side of the screen and push the left side of the screen. So hopefully, I know this is remote, but hopefully you can understand this is an intuitively obvious task. This requires inhibition. And we gave them on this computer screen a mixture of congruent, which makes sense, incongruent, which means, okay, now there's a group of flowers and you have to inhibit yourself. And then the hardest part was the mixed, which was flowers and hearts in a mixture. And let me just say that this little girl is not representative. She was one of the researchers' children. Most children absolutely hate this. I actually had to test the program to make sure it worked before we tried it out on children. I personally hated it. It's a very boring experience and a very annoying test. And what did we find with children who had no methamphetamine use, some or heavy methamphetamine exposure? And what we found was, in terms of timing, there were no differences in any of these tasks between any of these groups. Congruent, you see the heart, it obviously makes sense. You don't have to inhibit, so the reaction time is going to be faster. The incongruent, I see a big row of flowers, and I kind of get used to it. It's going to take me a little bit longer to react, and the mixed takes the most time to react. There were no differences in reaction time between the two groups. However, it's not the reaction time you care about, it's the accuracy. And that's where it fell behind. For the congruent, there were no differences between the two groups. However, for the incongruent, the flowers only or the mixed, where we mixed in flowers and hearts, the children who had the heavy methamphetamine exposure were much less likely to be able to inhibit themselves and produce the correct response, either in the incongruent task or the mixed tasks. Those who had some methamphetamine use or no methamphetamine use were pretty much performed the same, but those heavy meth exposures caused them to have an issue with executive function. Another attention task we used was, again, a very boring screen where they had to respond to every object on the screen except when the soccer ball came on. Again, a very, very boring, annoying test, especially for someone who has attention issues. And those who had methamphetamine exposure had subtle differences in attention processing and higher attention deficit, higher hyperactivity disorder, ADHD confidence index scores, suggesting a greater future risk of developing ADHD. Behavioral outcomes at age 7.5 for these children, again, they had more likely in the methamphetamine group to have externalizing, rule-breaking, aggressive behavior. We're almost to the end. I'm going to show you some data about body growth because there was concern about methamphetamine children and how they grew. In Sweden, at birth, 1 year, and at age 4, weight, height, and head circumference in children who were exposed were below the means of their peers, and at 10, females were shorter than their peers. So that was that Swedish group, the 65 children without the control group. So there seemed to be concern about growth. What did we find? We found that children who were methamphetamine exposed were more likely to be born small for gestational age. But as we tracked them, the good news is they didn't have any issues with their head circumference, which is brain growth causes head growth. There was no differences. There were no differences in body weight, and very, very subtle differences between the exposed group and the comparison group with height trajectory, which is your genetic height potential. Very, very subtle differences by age 3. Here there were some differences here, and there really weren't differences by age 3. So in terms of growth concerns, body growth concerns, I would say that the issues are not a concern for children that are exposed to methamphetamine. So in summary, what do we know? We know about children at birth that they're more likely to be born small for gestational age. They're difficult to arouse and more stressed, but by 1 month of age, the arousal and the stress is no different than children who are not exposed to methamphetamine. At 1 year, they had a lower score on fine motor skills, but no issues on fine motor skills by the age of 3. Their IQ at age 3 was fine. They had a modest decrease in height growth trajectory, but not nearly so pronounced an issue as the small for gestational age at birth finding. So very modest issue. They had increased emotional reactivity and increased anxiety and depression, but not issues with attention at age 3. By age 5, they continued to have these anxiety, depressed, emotional reactivity increases above their unexposed peers. They had increased externalizing behaviors starting to emerge and increased ADHD issues. In addition, at 5.5, they had increased ADHD issues and reduced inhibitory control in heavy methamphetamine users, and an increased externalizing and rule breaking and aggressive behaviors at age 7.5. This is my second to last slide. I never close a talk without talking about Roger Carver, who at this time was 13 years old. He was written up, this was actually in Sports Illustrated. He had been heavily exposed in utero. Shortly after birth, had been adopted by a family who noticed at about age 4 that Roger had an abundance of energy, to say the least. But they noticed that when they took him up to Lake Tahoe and put skis on him and eventually a snowboard, he was incredibly focused and incredibly excellent. And by the age of 13, he had earned an incredible number of national titles for snowboarding for his age. This is Roger Carver as an adult. I love this picture. I don't know how he was able to keep his neck up after having won earned all of these awards. He actually became quite a gifted adult snowboarder, had been training for the Olympics, and had made great progress, and he was in the snowboarding field. He had, if you will, he had a contract. I think he's very gifted in snowboarding, and has found his path in life. And I think if I want you to walk away with anything from this discussion, it is that there is incredible hope and things are really good for children who are exposed to methamphetamine, especially if they're in a supportive, nurturing home environment. And yes, there are some subtle findings. Yes, they tend to be in the domain of attention, though certainly not all children. There tends to be a bit of a dose-response effect. The heavier the user, the more likely you are to find it. But I will absolutely tell you, and many of you who are working in the field probably can tell me even more, that the hope, this is a story of tremendous hope. These children do very well in nurturing environments. These women, if they really can commit, and I've seen it over and over again, that this is the pregnancy that turns it around. There is tremendous hope for users who are newly abstinent, who get enough support. There's tremendous hope for these children. And so I think I'm going to end it there. I have some references for you as well, but I will end it there and end it, I think, with this slide of hope. Hello?
Yes. Thank you, Dr. Smith. Does anyone have any questions? This was a great presentation with lots of information. Hopefully you all got something out of it. If there are any questions, we can put them in the chat box. I don't want to unmute everyone. I think there will be a lot of background noise. So if you have any questions, you can go ahead and put them in the chat box. Give you all a moment. Okay. So Anandi Davis says, do cocaine users also return the red part in the brain study after not using for a period of time? Do children of cocaine have the same hope? Great presentation.
Well, first of all, thank you for that feedback. In terms of the second question about children who are exposed to cocaine, yes, I would say 100%. They have that same story of hope. They do sometimes have similar domain of attention issues if they do have issues, but again, in a nurturing, caring, supportive environment, children who are exposed to cocaine do very, very well. And those data even extend into adolescence. If you are interested in, there's so many wonderful cocaine cohorts, if you will. Barry Lester, Lester, and had a wonderful, it's called the MLS study. But there are so many, Lynn Singer, there are so many stories of hope with cocaine. I will tell you that I am unaware that cocaine even causes a downregulation of those receptors. It is most pronounced in methamphetamine because the dopamine stays so long. So because the cocaine high, if you will, is relatively significantly shorter than methamphetamine, I don't even know if it is downregulated, to be honest. But certainly, if it is at all, the story with cocaine would be, I think, even more hopeful because it's not near, those receptors aren't exposed to so much of that message. So there's not the need to downregulate so strongly.
Okay. Just as a note, Anandi also says, I believe we see more cocaine use in homes than meth, and that meth is caught at the hospital. And she thanks you. I certainly, what I would say is that in our city, there are pockets of use. In the South Bay, in the high desert, it tends to be methamphetamine. You go up the road maybe 10 miles and it might be more cocaine or it might be opiates. In the hospital, when we have concerns and a suspicion, we run a test on the mom and on the baby, and both of those tests will pick up recent cocaine, methamphetamine, opiates use. It's possible what you're seeing is that the cocaine gets out of the system a little sooner, maybe, remember, because the methamphetamine lasts a bit longer, and that's very possible that you are seeing it. It may be that your clients that you are serving are in geographically an area that's more cocaine use as well. I absolutely will tell you, there are women who have tried methamphetamine who don't like cocaine, and women who have tried cocaine who don't like methamphetamine. So I do believe that there are brain chemistry differences between individuals, just like, some people, opiates work great for pain, and other people say, I can't have codeine, it's the worst thing ever for me. So I believe brain chemistry can also alter what one uses. So perhaps where you're working, cocaine is the drug that is used more frequently, but when they are tested in the hospital, there's usually a pretty standard panel that should pick up both.
Thank you. Are there any other questions for Dr. Smith? Okay, so if there are no more questions, we have recorded this webinar and we'll make it available. I will send out the webinar link, the link to the recording when we have it available. I will also send out an email with the slides if I can get them from Dr. Smith. And yeah, if anyone has any other questions, feel free to email us and we will try to get that information out to you. So everyone, we're ending a little early today, so you get an extra half hour back of the day. I hope you have a wonderful rest of your day, and we'll talk to you next time. Thanks again to Dr. Smith for a really informative, thorough presentation.
Thank you very much. I appreciate the invitation.
Okay. All right. Bye, everyone. Thank you.
Can I stay on with you for just a second? I hope this was okay. I just feel like people, I'm happy to answer any questions someone might have later, but this is, I purposely truncated it to an hour because people really lose their focus. I hope that was okay.
Absolutely. That's totally fine.
All right. Is there anything, I will do my best. I may have to PDF it because I've tried to send it before, and would you be okay if I PDF'd the slides?
Absolutely. I think as long as everyone gets the information, that'll be totally fine.
All right. Well, thank you so much for the invitation. I do appreciate it.
Yes, thank you for sharing your work.
Take care.
Okay, bye-bye.